So good morning, everyone. This is episode 3 of Prostate Cancer Prostate Disease podcast. I have the pleasure to present this important article by Dr. Ferriero, The Impact of Local Regional Treatments for Metastatic Castration-Resistant Prostate Cancer and Disease Progression, Real-Life Experience from Multicenter Cohort. Probably is a very debatable cohort of patients, so we will try to go inside this big panorama of new treatments for metastatic castration-resistant prostate cancer. And Dr. Ferriero, who I'm introducing right now, works in a very big load hospital, so will actually give us a very wide perspective of what the local regional treatments may be. So I ask you to introduce yourself, Dr. Ferriero, and present where you work and what you do as your normal duties every day.
Hello, Dr. Lombardo and everybody. Thank you for your kindest invitation. I'm Maria Consiglia Ferriero, consultant urologist at Regina Elena National Cancer Institute in Rome, Italy. I work in Department of Oncologic Urology.
Okay, so what I wanted to know about this article is what was the idea to develop this study? Why did you develop such a nice multicenter cohort?
So in the long natural history of prostate cancer, the introduction of anti-androgen target receptor antagonists in metastatic CRPC setting delayed the more toxic chemotherapy, especially in low volume disease. So we started from this idea and this topic of oligoprogressive metastatic prostate cancer that is commonly defined as an established disease with only few lesions, 3 or less, progressing on a background of established metastases, remaining responsive to the current systemic treatment. So selective locoregional treatment of oligoprogression is still an emergent concept in prostate cancer, but no prospective randomized trial are available to demonstrate outcomes or advantage of survival outcomes of metastatic castration-resistant patients treated with or without metastasis-directed therapy. So in our study, we investigated progression-free survival after local regional treatments for oligoprogressive mCRPC in a real-life multicentric experience.
Okay, thank you. So I want to go through with you through your cohort, actually. So here we can see the characteristics of the cohort. Can you tell me something more? How do you feel this cohort is representative of? So because I think real life cohorts are very important because they are very similar to what we see in everyday clinical practice and far from what let's say, randomized clinical trials cohorts are. So this is probably patients that we can see in everyday clinical practice. And what do you think are the main aspects of this cohort?
So we prospectively collected data from patients with metastatic CRPC from 5 different cancers. And these patients were treated with abiraterone and enzalutamide as a first treatment line. And all these patients were treated with ADT and had castrate levels. In case of radiological progression, identified by conventional imaging or PET-CT scan if available, it depends on the center. Patients were treated with local regional treatment. The selection of the first treatment line of metastatic castration-resistant disease was arbitrarily decided by oncologists or urologists, and the staging was performed, as I already said, with conventional imaging or PET-CT only if available at the beginning and the on-site or CRPC diagnosis, and in case of oligoprogression. So in case of oligoprogression detected at follow-up, patient who experienced bone metastasis or lymph node out of the pelvis were treated with local regional treatment, such as SBRT in most cases, and robotic lymph node dissection in some cases. all these patients were treated with safe procedure since no high-grade complication rate were detected at after radiation therapy or robotic lymph node dissection.
So can I ask you, in your experience, actually, because you see a lot of these cases, is it really a difficult procedure to perform in these patients, or do you feel it is a procedure that you can, because we're always afraid of recurrences, we're always afraid of doing lymph node dissection, especially if the patient was previously treated. So I believe that you can really tell us if this is something we shouldn't be afraid of, or if you believe that we should actually be careful with these cases and send them to high-load centers which can manage this kind of surgery.
Of course, it is a real-life experience, so we collected data from different centers with different fashion to treatment to treat patients. So in many of the high-volume centers, robotic lymph node dissection can be safely performed. Of course, patients should be strictly selected after a discussion in multidisciplinary team. And if fit for surgery, lymph node dissection with a limited yield to the identified recurrence should be performed.
Mm-hmm.
Otherwise, SBRT should be a useful alternative to surgery.
Okay, thank you. Let's go through your results of your study. So you find very meaningful results, and I think that they actually are very close to what we have in the literature. So can you tell us a little bit more about your results, and if you were happy to find these results, and what do you think about them actually?
So out of 117 chemo-naive mCRPC patients, they received a first-line therapy with abiraterone and enzalutamide. 28 experienced progression, and some patients received chemotherapy after first-line progression because of a wide and significant progression of disease, while other patients received a second treatment line. 25 patients received oligoprogression and were treated with SBRT or robotic lymph node dissection. And post-operative course was uneventful in case of lymph node dissection. High-grade toxicity was not recorded in any case after SBRT. We included all variables in a Cox regression analysis, but no features displayed a role on progression-free survival probability. Instead, at Kaplan-Meier analysis, high-volume disease was a significant predictor of lower progression-free survival, as you can see in the figure 1. And if you move on, okay, the local regional treatment did not impact on progression-free survival in the whole cohort, while and in high-volume cohort, while in low-volume disease, there is improved progression-free survival probability using local regional treatment.
Okay, so I really believe that this is what you actually took into practice what we all believe, right? Because when you have high volume disease, it just goes against local treatment. I mean, it's almost an antagonist of the word. So it's something that to see it, I think, in a real life cohort, it really changes a little bit our way of thinking especially when going to multidisciplinary teams, because nowadays, I think that all patients are very different because now we have a lot of treatment options. So as you said, it's a real life cohort. And I think the main characteristics of this cohort is that everyone made what they had in their center, their protocol. So they decided which kind of imaging technique to use. And they actually made the decisions with the MDT. So this is what real life practice is giving us. So I would like to know how you
Yes,
manage
it is the strength of real life study, but also a limitation due to different arbitrary choice of first line treatment option or local regional treatment, the staging system, and of course the role of staging system at diagnosis and the onset of CRPC, and in case of progression, it is crucial the role of PSMA PET CT scan.
So do you think that PSMA PET would have changed the results of your study? Do you think that this is an advantage? Because a lot of people say that sometimes you may end up in the high volume cohort instead of the low volume cohort, actually, because it's very sensitive as a imaging modality. So what do you think about this topic?
Yes, actually, the EAU guidelines acknowledge the high accuracy of PET-CT and detecting the real volume of prostate cancer, but no other data are available to address subsequent management. Nonetheless, there are some recent data demonstrating the role of PSMA PET in detecting progression in cases of patients treated with enzalutamide or abiraterone. In our cohort, most patients were staged using the PET PSMA, but it is not always available in all centers. And specifically, all PET CT scans were performed not always with PSMA as a radiotracer. So it is a useful tool, but not always available everywhere. And of course, it can change the stage from no metastatic to metastatic and from low volume to high volume disease. So it is a real crucial role in the accuracy to stage prostate cancer and in order to manage and promptly identify the local regional progression and subsequent treatment of disease.
Okay, and in your everyday clinical practice, how do you manage these patients? You have an MDT, who is in charge of the patients? How, because you're a big oncological hospital, so we would like to know how you manage these patients in everyday clinical practice.
So yes, we have a multidisciplinary tumor board with a weekly meeting in which all cases were discussed with oncologists and radiation therapists. Most cases are presented by urologists, but also by oncologists. Of course, it depends. They are managed subsequently after discussion by urologists in case of surgical treatment, by radiation therapy in case of SBRT, and in case of chemotherapy by our oncologists.
And do you feel that urologists are able to manage these complex cases? Do you feel it's its role, or do you think that these patients, because in many countries, these patients are just abandoned by urologists, and so sometimes I think that local regional treatments are not proposed or are not really deeply discussed because the oncologist probably will just end up putting these patients in a clinical trial to try new drugs or to try different types of treatment. So what do you think urologists should do or should not do in this kind of patients?
I think that the introduction of the novel anti-androgen receptor targeted agents significantly changed the natural history of prostate cancer disease. So urologists, as a primary surgeon, now play an active role in the management even of metastatic disease. So they are integral part of multidisciplinary boards participating in decision making alongside oncologists and radiation therapy. The adverse event of this drug should be easily managed by urologists. So the role of urologists in this setting is increasing in the last year, and this could be a crucial role for urologists even in the future, especially to the introduction of these new drugs and to the possibility to study patients with molecular profiles. We can choose the most appropriate and tailored treatment thanks to these studies.
Okay, so you talked about tailored treatment. So I think a very nice hot topic to introduce is the role of focal treatment in these cases. So probably they have a role mainly in local recurrence more than in lymph node recurrence. But what do you think about the possible role of HIFU, cryo, or the most recent TPLA in this setting? Do you think they have a role? Do you think that it may be better to manage them surgically or with radiation therapy? What is your experience in this topic?
In our clinical practice, cryotherapy and HIFU are the most used alternatives to surgery, especially for treating the wall gland. So we prefer, in case of oligoprogression, to treat bone metastasis with SBRT and not with cryo or HIFU, and to use robotic lymph node dissection if the lymph node can be resectable and within the pelvis. So in case of in case of recurrence in the pelvis that the urologist can manage with surgical approach, we prefer the surgical approach and use the ablative treatment just in case of patient unfit for surgery or in case of patient who refuse surgery.
Okay, so another important thing is that I think that the two new entries such as PARP inhibitors and lutetium PSMA will complicate even more the panorama, so complicating life of everyone, because as you really introduced 10 to 15 years ago, we didn't have any option for these patients. And now we have a big menu to offer to the patient. So I would like to know what's your experience with these drugs? And if you really believe that they have a role in this setting, and what role do you think they may have in the future?
PARP inhibitors represent a further chance for treatment of metastatic CRPC, even if the efficacy is linked to the BRCA1/2 mutation. In addition, in Italy, this drug can be prescribed only by oncologists seen nowadays. So maybe in the further future, we can use as a urologist a PARP inhibitor, even if, as I already told, the rate of mutation is around 7–10% in this population of patients. So it is a good opportunity, but not always applicable. Instead, concerning lutetium PSMA in mCRPC, several analyses established the anti-tumor activity of lutetium PSMA in this setting, and some studies demonstrated as assumed tumor volume and the number of metastases detected at PET-CT can impact on overall survival of patients with metastatic CRPC treated with radiometabolic treatment. So theranostic is the present and the future may be for high volume disease. So if in case of oligoprogression, we prefer to apply local regional treatment, lutetium PSMA treatment should be choose in a case of high volume disease.
So what you mean is that we probably would offer, let's say, these such treatments to these patients on the left of this slide, right? So probably
Yeah.
patients would have had a benefit of such treatments. I think this is a nice way of seeing things nowadays. I think that it's a clear message for people who don't see a lot of these patients, because you probably have the opportunity of seeing this every week in your tumor board, but it's not that common to find these patients who have all these alternatives in the same center. So to finalize a little bit, because I think we went through all the aspects of this complex topic, I want to know what you think is missing in the literature. What should we actually focus on in the next 5-10 years to improve the management of these patients, especially considering that the panorama will change a lot when introducing a lot of drugs, or in a neoadjuvant setting, or in a concomitant treatment with or adjuvant or immediately adjuvant. So we will lose a lot of skills in the future. So probably the next metastatic castration-resistant patients won't have the same history as the ones you presented in your paper. So what do you think we should focus on in the next future?
The idea is to delay the shift to further treatments, or delay the more toxic chemotherapy with the use of ARTA as a first treatment line, first of all. And I think that the literature is lacking or more reliable data concerning the impact of these local regional treatments in metastatic castration-resistant prostate cancer, even if real-life experience can report the idea of what we can do in our clinical practice without the selection of the trials. So a more accurate diagnostic tools and the study of molecular profile in patients with metastatic CRPC patient could help to promptly identify progression and choose the best treatment for patients in this setting to prolong survival probability.
Okay, thank you very much. I think that the main point of all what we have been through is to actually what has been the history of prostate cancer, so that we are still lacking inadequate staging, because I think we have to acknowledge that we start with a 20% upgrading after biopsy. So the start is just not good, actually. So I agree with you that our main efforts, and probably genetics, will help us to define a little better what cancer we are treating, because now we are treating all the patients the same, and with all these different options, probably selecting. And I think the word that you said before, tailor, is the word for prostate cancer management. So I think I can conclude. I really thank you, because it was a very nice conversation with you. And I think we can actually congratulate you for this very interesting paper, which opens and gives a clear message. So high volume, there is no way for local regional treatments. Low volume, go for it and try. You will have good results if you go for it, even if what you did before is not the same. So that's I think the main thing that we have to retain from this paper. Okay, so thank you a lot.
Thank you again.